So one of the main takeaways from our article is that primary care physician turnover is costly, and it results in about $1 million worth of avoidable healthcare expenditures every year. These are costs that are borne by the patients and by the payers, both commercial payers and public payers such as Medicare and Medicaid. The portion of that cost that's related to primary care physician turnover due to burnout is about 25% of that, or about $260 million every year. I'm Christine Sinsky, the Vice President of Professional Satisfaction at the American Medical Association.
And I'm Colin West, Professor of Medicine, Medical Education, and Biostatistics at Mayo Clinic in Rochester, Minnesota, and privileged to be a co-author with Dr. Sinsky on this work.
And today we're talking about a publication, Healthcare Expenditures Attributable to Primary Care Physician Overall and Burnout-Related Turnover, a cross-sectional analysis. And we might wonder, what could account for this burnout turnover associated cost? Why is it that when patients lose their primary care physician, costs go up? Well, one reason is that if patients seek care at all, they might be receiving care from a physician who doesn't know them as well. They may be going to urgent care or to the emergency room. And in those settings, when the physician and the patient don't have a strong relationship, it's more likely that more tests will need to be done, more additional appointments might need to be made, and all of that contributes to additional cost. And what that means is that continuity is one of the keys to good quality of care. When there's continuity between a primary care physician and their patients, there are better outcomes, better diagnostic accuracy, patients are more satisfied, there are fewer ER visits, fewer hospitalizations, fewer readmissions, and lower costs altogether.
Our analysis in this study builds on the work of our collaborator on this manuscript, Dr. Adrienne Sabity, who previously estimated the excess costs per Medicare patient when a primary care physician leaves the organization by considering costs for representative panels of Medicare and non-Medicare patients in primary care. We drew from prior national surveys that we've conducted and nationwide physician data files to identify rates of burnout among physicians by specialty, quantify the relationship between burnout and intention to leave one's practice, and other work that has further quantified the relationship between stated intention to leave and actual departure. For example, there's previous literature to suggest that at minimum, 25%, with numbers ranging quite a bit higher than that, but at least 25% of physicians who report an intent to leave their current position in the next 2 years have been seen to actually do so, actually leave those positions. So we use that as one conservative input for our analyses. I'll say a bit more about that in a moment, but the summary results of that approach were, as Dr. Sinsky mentioned, an estimate that PCP turnover results in nearly $1 billion in excess healthcare costs annually, with more than $260 million of this attributable to burnout-related turnover among primary care physicians. So there are a number of limitations in the analysis that we conducted. We tried to be conservative every step of the way in generating these calculations. What this means is that this $1 billion figure is almost certainly an underestimate of the true costs. So some of the elements that we included were estimates of what the primary care physician turnover rate is, estimates of a typical panel size in primary care, using estimates of non-Medicare patient care costs versus Medicare patient care costs, and extending those not just for adult patients, but also for pediatrics patients. We also did not include the costs of reducing clinical effort within the same practice without a complete departure. And we also considered physicians providing primary care only, as opposed to the many other healthcare professionals that are involved in primary care across the United States. So to put this in context, there are other sources of costs attributable to burnout that are borne by healthcare organizations and by the entire US healthcare system that would further increase the costs beyond what we've estimated in this paper. So burnout among non-primary care physicians, as I already mentioned, likely also introduces excess healthcare costs. Burnout has also been linked with malpractice, misdiagnosis, and other errors. Physicians who are experiencing burnout may have greater difficulties engaging in trust-based relationships that promote shared decision-making and adherence to treatment recommendations by patients as part of that relationship. And of course, there are also replacement and vacancy costs to organizations from burnout that have been documented in previous work. So what is the next step for this line of research from our perspective? Well, two main steps that we will continue to work on are first to further refine our estimates of the costs of burnout across all of healthcare. We need to consider other specialties beyond primary care, and we need to think about other professions in medicine. The second main step is to continue work to identify solutions to benefit both individual healthcare professionals in what should be rewarding, meaningful careers, and solutions that benefit the healthcare system as a whole. We're all in this together: patients, individual healthcare professionals, our healthcare system as a whole, all need to be working together for collective benefit. And then finally, a couple of other concluding points. First, it's important to note that one way that payers, both commercial and public, can reduce healthcare expenditures is to be concerned about healthcare professional well-being and physician burnout in particular. In short, it impacts their bottom line, their costs. And we believe that addressing physician and other healthcare professional burnout is a shared responsibility across every stakeholder in the healthcare community. This includes policymakers, regulators, technology vendors, institutional leaders, payers, individual healthcare professionals, and even patients from an awareness standpoint of advocating for the best healthcare they can possibly receive. The arguments are both moral, in that a healthy workplace should be an expectation in the modern era, and financial, as work like ours demonstrates. This is simply good business.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.